Okay, good afternoon, everyone, and welcome to our first edition of our Women's Series for Girls Flow Free. My name is Adwoa Amoateng Gyamfi. I'm the founder and director for Girls Flow Free. And this afternoon, we are very privileged to have Dr. Osei Asibey Owusu with us. Not only is he going to take us through this session, but we are happy to say that Dr. Osei Asibey has joined our team, and we are very fortunate at Girls Flow Free to have him with us. A bit of introduction about who this person is. So Dr. Osei Asibey Owusu, and it will surprise you, I thought Dr. Osei Asibey was his surname. So I sent him a message and I'm asking Dr. Osei, can you please give me your first and your full name? And then he says, no, Osei Asibey is my full name and Owusu is my last name. So he's a medical doctor trained in Ghana and he has over 10 years experience in general practice and then in ops and gynae. Dr. Osei Asibey has his master's from the London School of Hygiene and Tropical Medicine, and he is currently undertaking a PhD in clinical epidemiology at the University of Exeter here in the United Kingdom. Dr. Osei Asibey, thank you very much for making the time to speak to us this afternoon. I know I only spoke to you was it last Saturday or Sunday? But then, it was on Sunday.
Yeah.
Yeah. But because of his passion and his interest in women's health, he gave us his availability for this Saturday. So, Dr. Osei Asibey, we are ready to hear what you've got to educate us today on uterine fibroids. Yes. So we are ready when you are. Thank you.
Thank you very much. Sophie, it's also a privilege to also be here to talk to you on uterine fibroid. The last time we spoke, I told you about my passion about it because a lot of people around me have had the issue of having to be diagnosed of this condition and how it has affected their life. So I'm really passionate about this topic and I want to educate a lot of people, mostly people who are living in the diaspora, because it's a condition that mostly affects Blacks, and most of the doctors trained not in Africa don't have a lot of experience, and the life experience of people living with this condition can be very, very stressful, and we need to let people know about the condition and how they can easily approach healthcare systems to receive the best of treatment. So yeah, it's a privilege for me to be here to talk to you about this. Please, can you see my screen? Is it showing?
Yes, it's sharing.
Okay, good. Okay. Where is my Zoom? Okay. So uterine fibroids are you can call them myomas. That I think that's the most common name within the medical fraternity. Is called myomas, or leiomyomas or fibromyomas. All these names has a reason why they are called like that. They are called myomas because they are benign tumors. If you say benign tumors, they are tumors, but they are not cancerous, if I should put it that way. And they are also called leiomyomas because they come from smooth cells. The uterus is mainly made up of smooth muscles. Smooth muscles are very, very, very smooth. Most of the organs we have within the body have smooth muscles. The organs for locomotions are made up of skeletal muscles. These ones are made up of smooth muscles. And the nature of it is more of a fibroid. It's made up of more of like a fiber. So it's called fibromyoma. So the three names tells how the appearance of it And if you can see the pictures over here, that is a diagram of a uterus and how these fibroids can appear within the uterus. The second picture tells of how the fibroids actually is on the uterus. So the organ below is the uterus, and that thing growing on top of it is the fibroid. And you can see a lot of blood vessels around it, and that's how they appears like. And the other one on the third picture is when you have removed the fibroid. That's how it looks like. It has like a false capsule around it. Very, very solid, very, very firm. And though that's the one also shows a similar like the first one. Now, I said they are benign tumors because they are not cancerous. It won't destroy the host body if they are there, but it has its own effect on the host body if they are present. Okay, and they occur in more 20 to 40% of women in reproductive health. And I mean, we're talking about almost 40% of all women within their reproductive health might experience this condition. And that's how sometimes, that's how trouble they may be like. Now, what are the risk factors for fibroid? It mostly occurs within the late part of the reproductive health. So between the ages of 35 to 45, that is where you mostly see fibroids with its effects. And I'll explain why it happens within that period of time. Now, it also happens among people who are nulliparous or low parity. If you say someone is nulliparous, someone who have never given birth before, or who have a low number of childbirth, so mostly 1 or 2 births, they have increased risk of fibroids. And people of Black heritage and families of Black heritage. Now, I'm going to take my time and explain the first 3. Now, one of the concepts that we've gotten to understand, and I'll go into the etiology of it later, is that fibroid is mostly linked to estrogen. Now, it's linked to estrogen, which means that as a woman, you are at risk of developing fibroid because every woman has estrogen. So the long and the prolonged exposure to estrogen causes the development of fibroid. I'll put it this way. When you give birth, there is an interruption because estrogen is one of the hormones that regulates your menstrual cycle. But the moment you give birth, over the period of the 9 months, the level of your estrogen level diminishes or decreases significantly. So if you've not given birth, it means that your uterus is constantly subjected to estrogen. That's why people who are nulliparous or who have low parity are at risk of it. And after 30 years, it means that your body had been subjected to more than 20 years of estrogen levels, and that can also result. Now, obesity is one of the increased risk of childbirth, increased risk of fibroid because it is known that when people are obese, they also have increased estrogen levels and they also have it. Then if you have early menarche, which means that you started having your menses at an early stage, that also means that you'll be subjected or exposed to estrogen for a very longer time, and that will also increase your risk of fibroids. Some conditions such as diabetes and hypertension have also been seen as a risk factor in fibroids. Now, the thing that decreases your risk, if not giving birth increases your risk, that means that people who have increased birth rates reduces risk of fibroids, because I said during your pregnancy, like for the 9 months, your estrogen level is taper down significantly and your body is not subject. So that reduces your risk. Exercise, intake of very green vegetables, and it is known that people who are on progesterone-only contraceptives reduces their risk. There is a very weird, not epidemiological, if I should say, more of an observational study which shows that if you take e-cigarette, it reduces the risk of fibroid, but it's one of the decreased risk factors that you have to look at in quote because they may not be a direct causality for it. So I'll just put it there, but it's something that I don't put in a lot of weight on. Now, I started saying that.
Dr. Osei, before you go on, there is a question on the risk factors.
Okay.
So the question from Charity is, what is considered early for menstruation, 10 and below?
Yeah. So menstruation, things are changing. Some 10 years ago, menstruation was averagely was around 14 years. Recently, it has been reduced to 12 years. That is what we know. But there is records of even between 7, 8, and 9 years kids having their menses. So any menstrual cycle starting somewhere earlier than like you said 10 years or 11 years can be said to be an early menarche.
Okay, thank you for clarifying.
Yeah, you're always welcome. Okay. So on the cause of uterine fibroids, the etiology is not clearly understood. It's not clearly understood as to what exactly caused the fibroids to start growing. It's not clearly understood, but there are things that gives us a clue about them. So I initially said that the uterine fibroids are mostly smooth muscle tumors, because the uterus itself is made up of smooth muscle. So it arises from the smooth muscle cells of the myometrium. So the cells within the smooth muscle give rise to the uterine fibroids. Now, one significant thing is that it is a monoclonal origin. When we say it's a monoclonal, it means that it arises from just a single cell, which means that it doesn't affect the whole uterus, or it doesn't invade into the whole uterus. It just arises from a single cell. That is why fibroid can be easily taken out, because it's just arising from a single cell. The other thing that we also know that it has a lot of genetic basis. Okay. Now let me go back another step. I said that there is a strong correlation between people who have Black ancestry or whose parents have African ancestry, or if your parent once had a history of fibroid, you have a high risk of developing fibroid. This is really a strong genetic correlation. So it is believed that Caucasians mostly don't have fibroids. It is believed. If they do have, then they should have had maybe a Black ancestry, maybe down the line, and that's how they develop it. So it's something to do with Africans, and why we developing it is still not clearly understood. But one of the things it's known that it also have a link to what we call growth factors. Growth factors are the things that allow everything in our body to grow. Everything in our... Sorry. Just a minute.
Okay.
Please, can you hear me?
Yes, we can.
Just, I do apologize for the quick interruptions. Okay, so it is also known to be associated with some growth factors. These growth factors, as I said, are responsible for normal growth in our body. So anytime there is something causing a rapid growth in our body, if you have uterine fibroids, they might respond to that thing that is causing you to grow. So let's say in pregnancy, if your baby is increasing and the uterus is developing in size, if you have a uterine fibroid, it will also increase with that. And that is something that we're still looking into to know exactly why that is the case. Okay. Now, on the genetic basis, it is believed that 40% of the causes of uterine fibroid are genetics. So to do with your family, to do with the fact that you have an African ancestry, to do with some specific chromosomes, which we believe it's chromosome 12 and 14. I don't want to go into the details, but I'm just mentioning for the fact of we knowing has a relation with you developing a fibroid. Now, the second etiology is the component, which is the estrogen component. Now, the reason why estrogen has been seriously linked to fibroid is because no one develops fibroid before puberty, which means that until you start having the surge in estrogen in your body, you don't develop fibroid. Then the rate of the fibroid mass significantly reduces the moment you enter into menopause. The moment you enter into menopause, all the uterine fibroids start diminishing in size, and some of them even vanishes. The other thing is the high incidence in nulliparous women. I told you, when you give birth for 9 months, your level of estrogen diminishes significantly. So your body is not exposed to estrogen. So it's high incidence. People who have never given birth also has a correlation to do with the estrogen. It's very common in obese women who produces more estrogen than non-obese women. It may increase during pregnancy, and studies have shown high concentration of estrogen receptors in the mass itself than in the uterus. That tells us that it must have something to do with estrogen, but as to the mechanism, it's not well understood. And that's where research is still undergoing to understand this. Okay, so let us understand the types of fibroids. So if you see the diagram on my left, it gives us a clear picture of what a uterus will look like. So there are 3 major types of uterine fibroids. There's what we call intramural. We say intramural, the mural is coming from the muscles, which means that when the fibroids develop within the uterine muscles, it just develops within the walls of the uterine muscles. So that you don't see it in the cavity, neither do you see it outside the cavity. You only see it in the walls of the uterine fibroid of the uterus. Is called intramural. Then we have what we call the subserosa. So if you can, I don't know, is there a way of me getting a pointer? I don't think there is.
We could see your mouse moving around. So if you try it again, yes, we can see your mouse.
Oh, good. So
yes,
these ones, the one I'm showing and the one here, are what we call subserosa. Now they develop on the outside of the muscle. So this is the all this side is what we call the uterine wall. So these are what we call the intramural. You can see it's developing within the uterine wall. These are what we call subserosa because they are developing outside the uterine wall. It's called subserosa. All of them have a significance and how they affect the individual. Those who develop some symptoms may be attributed to the fact that the masses are developed within the walls, outside the walls, or into the wall, into the uterine cavity, has its own clinical presentation. So this is what we call the subserosa, and that is also called a subserosa, but this one we call them a pedunculated subserosa. What they do is that they grow out of the uterus, and some of them can even detach from the uterus and attach to another organ, such as the liver, the intestines, or any other organ that can give them enough blood supply that the uterus is giving them. So they are called parasitic fibroids. They can detach away from the uterus, find another blood source, and start going there. Now, these ones, which you can see here, and that one is called submucosal. What they do is they grow from the inner part of the uterine wall into the cavity, and they also have their own problems and how they can affect the individual when they start growing bigger than they're supposed to do. So they bulge into the uterine cavity. They can also be very pedunculated and sometimes protrude out of the cervix. I don't know whether anybody have heard of polyps before. This is how polyps are developed. They are uterine fibroids that have developed into the cavity, and they start coming out of the cervix, which is into the vaginum, and that's how it is. So these are the three main class of uterine fibroid, and each one of them has its own clinical presentation. Now let us look at some of the clinical presentation. How do you know, or will you know, that you have uterine fibroid? The very common presentation of uterine fibroid, and sometimes we call it asymptomatical because people tend not to look at it much or put a lot of emphasis on it because the abnormal uterine bleeding can be associated with any other thing also. So when we say abnormal uterine bleeding, what do we talk about? We are talking about when you bleed excessively during your menstrual period. It can be called an abnormal uterine bleeding. Or when you are changing more pads than you are supposed to be changing, that can be, we call it menorrhagia. You are bleeding excessively than you are supposed to be bleeding. The another thing is that when you bleed in between your menstrual cycle, you know that your menstrual cycle is about 28 days, and maybe after 12 or 15 or 14 days, you start bleeding again. That in between could be as a result of the uterine fibroid. Or your menstrual cycle becomes very irregular. Sometimes comes early, sometimes comes late, or sometimes you don't know what happens, it doesn't come at all. This could be signs and symptoms of uterine fibroid. Now, because you are bleeding abnormally, you can easily go into anemia. Yeah, I've seen a patient that was always reporting to the hospital with HB lower than 4 because of uterine fibroids. She comes to your hospital, you see her HB, and you are running just to make sure that she survives, because she was always heavily bleeding anytime she goes into her menses. She always comes to the hospital or is admitted because of the uterine until we removed all the fibroids from the uterus and she became free. So anemia is a very common presentation. Pelvic pain. Now, some of these uterine fibroids can go deep into the pelvic structure, compressing on some of the nerves or some of the structures or some of the viscera. And when they start compressing it, they give you a lot of pelvic pain or sometimes back pain. So that is also another thing. If you have been developing some pelvic pain, you don't really understand where it is coming from, you have to check if it's not a uterine fibroid. Now, remember I was telling you that there are different types of uterine fibroids. Now, the pedunculated one, was someone talking? The pedunculated ones, which can detach, can turn on its stalk. So let me go back to it again. So this one, it has this small thing called a stalk. They can turn on it. And when they turn on it, it's called torsion. And this torsion can so much press can so much give you a lot of pain. Sometimes it becomes even emergency that you have to take you to the theater and remove it instantly. Now, some of the other things are some of the uterine fibroids can be infected. Sometimes they can be expelled out of the uterus, or they can undergo what we call red degeneration. I will explain these ones later on. Red degeneration is that when the blood supply to the uterine fibroids are cut off, or there's a competing thing for that blood supply. Because they are not there, the uterine fibroids start degenerating and undergoing what we call necrosis. And when they undergo, they call what we call red degeneration, and it gives a lot of pain. Dysmenorrhea is when you have menstrual pains during your menses, and it could be as a result of the uterine fibroid. Now, I started talking about the second clinical presentation. It's called pressure symptoms. Now, let me take you through a little bit anatomy. Now, can you see this one where my cursor is going?
Yep.
That is the uterus. Do you understand? That is the uterus. Now, in front of the uterus is the bladder. So this is your bladder, which keeps your urine. And behind this is what we call the rectum. That is the last section of the intestinal bowels. Now, when there is, let's say you have what we call a subserosa. Subserosa means that the uterus is, the fibroid is growing out of the uterus. So they are going outside here, or they are going somewhere here. They are going somewhere. The uterus or the fibroid can press on the bladder. And when it presses on the bladder, you have always the urgency to go and urinate. So we call them pressure symptoms. Because of the pressure on the bladder, you are always feeling like you are going to pee. So sometimes the common presentation of uterine fibroid is that the person can't stay more than 20 minutes without having to get up to go and pee. So they have urgency, frequency, incontinence, and sometimes the blood, mostly those ones which develops around the cervix area, they can block the neck of the bladder so that sometimes you can't even pee. You retain a lot of urine, you want to pee, and it wouldn't come out. So that's one of the urinary symptoms we call the urinary pressure symptoms. Then the bowel pressure symptoms, when the mass develop from the posterior aspect of the uterus and start pressing on the rectum, then you have constipation. So these people will have frequent constipation, no matter the amount of bowel movement medication you give to them, it wouldn't solve it because there is a mechanical obstruction. And they have intermittent intestinal obstruction too. And these are some of the things that you should be looking out for. It could be as a result of the uterine fibroid. Then the last one, which most people don't take it, you always have a sense that there is something in your abdomen. Always, you eat the slightest food you eat, you just feel like you are full. It could be as a result of the uterine fibroid. Now, other clinical presentations, abdominal distension, rapid growth, mostly during pregnancy, and sometimes when there is a malignancy, the uterine fibroid also grows rapidly. Now, the sixth one is some of the things that really bothers a lot of women, mostly people who take a little bit longer in their careers to conceive. If you develop a lot of uterine fibroids, mostly where they can obstruct, one, they can obstruct the fallopian tubes, or two, they can obstruct the transportation of the sperms into the fallopian tubes. Or the fourth one is when they prevent even a fertilized egg from what? Implantation. I will explain that. So let's say you have these pedunculated intracavity fibroid. It can block this entrance such that any sperm that is coming in may not be able to go through this fallopian tube to go and fertilize the egg. Or this one, which is over there, it makes the blood vessels over here so thin that even when a pregnancy is formed and it wants to attach, because of the presence of this one, it will not be able to attach, and the pregnancy will become miscarried and it comes out. So that's one of the problems when you have the intramural or the submucosal fibroids. They mostly affect pregnancy. Then the subserosa fibroids mostly causes the pressure symptoms, the bowel obstructions, the urinary symptoms, mostly are caused by the subserosa fibroids. Okay. Good. Now, one of the key effects of fibroid is on pregnancy. So pregnancy have effect on fibroid, and fibroid has effect on pregnancy. And some of these things will always happen. One of these things will always happen during pregnancy if you have a lot of uterine fibroid. So in the early stage of pregnancy, it can result in abortions. It can increase your pressure symptoms. You always feel like you want to pee. Now, malpresentation, if there is a huge fibroid, let me take us back to the diagram again. If there is a huge fibroid around this part of the cervix, and there is a baby here who is supposed to descend with the head, this particular fibroid here will prevent it from bringing the head down. So it might cause what we call malpresentation. Instead of bringing the head, another part of the body might be coming because of the huge mass formed at the cervix here. So that's one of the side effects of fibroids on the pregnancy. And they can also push the uterus so backwards that it will be very difficult for you to develop a natural birth, because the head will not be engaging the pelvis in such a way that it can precipitate labor, and you will have the urge to deliver. So that's one of the problems with fibroids on pregnancy. Now, during labor, when you have there was no problem with pregnancy, but you go into labor, what are some of the problems you will have when you have fibroids? Sometimes the fibroid itself can lead to preterm labor. They can cause you to have an early symptoms of labor, and that can be a problem. That was the case of my wife. The child was developed as a preterm because of uterine fibroids. And the other thing is that you can bleed extensively during pregnancy. You can bleed extensively during pregnancy. Then it's what we call uterine inertia. The contraction within the uterus might be affected, because the contractions start from the top part of the uterus and descend down to the cervix of the uterus. If there is a fibroid, the fibroid will either take the effect of the contraction, and that can affect also can affect labor. Now, there is something called dystocia. What it means is that the size of the pelvic or floor, or the size of the entrance of the pelvis where the head will be coming, is disproportionate to that of the head of the baby. And this can be as a result of a fibroid. If there is a fibroid sitting somewhere here, it will reduce the size, or it will reduce the space for the head to come, and the baby can develop what we call dystocia. And this can be a very serious problem during pregnancy. It can result in you losing the baby, or the mother can have a lot of complications after delivery. So that is something that we should be looking out for. Okay, then after delivery, if all these things goes on well, and after delivery, what mostly happens is that the place where the fibroid is attached, if it was the same place the placenta was attached, sometimes it's very difficult for the placenta to detach from the uterus after the baby has been delivered. And in your attempt to pull the placenta out, you can bring the whole uterus out. And that's what we call subinvolution. And it's a very dangerous situation, because when that happens, it means the uterus will never relax and contract for the bleedings to stop. You might be bleeding extensively. And if that does not solve, they might have to take away the uterus to prevent you having any form of emergency. So it's called subinvolution. And the second one is secondary PPH, postpartum hemorrhage. Sorry for the abbreviation. PPH is postpartum hemorrhage. Now, the postpartum hemorrhage also means that after when you have developed, because the bed of where the placenta was attached, there was a fibroid somewhere hiding there, the bed doesn't heal properly, and you can bleed from that part of the uterine bed again, and that can lead into what we call secondary postpartum hemorrhage. It can also result in sepsis after delivery, and also inversion. And so inversion and subinvolution are almost the same thing. The inversion is when the uterus come out. The subinvolution is the inversion is when its uterus come out with the inner part of it. The subinvolution is that instead of the uterus resting in its normal position, it will not rest in its normal position. It will rest in an abdominal position. And when that happens, the uterus will not be able to contract very well, and you can still go ahead and bleed. Now, let us look at some of the effects of pregnancy on fibroid itself. Now, when you get pregnant, if you have fibroid, this is what happens. There is increase in what we call the growth factors to prepare the uterus so that the baby can have enough of anything that it needs. Now, that same mechanism that is happening in the uterus can happen on the fibroid, because remember we said that the fibroid is still a smooth muscle and it is derived from one cell from the uterus. It will also do the same thing, and they can significantly become very big during pregnancy, and they become very, very soft. Now, in second trimester, when now the baby has a high demand of nutrient to grow, there is a competition for blood. And sometimes the baby wins. And when the baby wins, there is cut off of blood supply to the fibroid itself. And when that happens, the fibroids start undergoing what we call necrosis. They start dying. And when they start dying, they give a lot of pain. They give a lot of pain. So that's some of the complication pregnancy has on the fibroid. So there can be also impaction in the pelvis, because the uterus is getting bigger, the fibroid is getting bigger, and all of it is happening in the same small space in your pelvis. So your pelvis can be really impacted, and you can have all the pressure symptoms that you are having. Then if the fibroid was a pedunculated fibroid with the stalk, because the uterus is getting bigger and it's also getting bigger, it starts turning, because you see the uterus will start growing upwards while the fibroid is trying to also find its space. They can start turning and turning and turning, and you can undergo what we call torsion of the fibroid, and that is an emergency that can take you to theater as an emergency. There can be infection. They can have talked about impulsions. Now, if this particular uterine fibroid is so big, it can press on some of the major organs, like your ureters, like your bladder, like your intestine, and sometimes they can press on a very big blood vessel in such a way that the blood supply to the rest of the organs within your body can be affected, and that can result in a very huge injury. It can also cause some of the major veins within your body to rupture, and if that happens, you can undergo what we call internal hemorrhage. Internal hemorrhage is an emergency. If it happens to you and we don't take you to the hospital, you can easily die. You can easily die. Okay. Now, how do we diagnose uterine fibroids? So it's one of the conditions that can easily be diagnosed. Easily, if the symptoms suggest of it, just take an ultrasound. Now, if you can see these diagrams I have here, you see this circle over here, like a hypoechoic image over here. That is a uterine fibroid, and any scan can pick it up. Now, sometimes we are not very sure where the position of the fibroid is, so we want to be able to tell, is the fibroid in the cavity or is outside the cavity? Because we told you that when the fibroid goes into the cavity, it can be the reason why a person may not be able to get pregnant. So you can do what we call saline infusion sonography. You put some fluid in the uterine cavity and you take the scan again, and you see that the fluid is marking the uterus, the uterine cavity, and I can see this particular structure protruding into the uterine cavity. So that's where you're able to use this one to tell the difference between where the position or the type of uterine fibroid, whether it's intramural, submucosa, or subserosa. That is it. Then there is this device called hysteroscopy. Now, we also mentioned that there can be pedunculated fibroid within the uterine cavity itself. You can use the hysteroscopy. What the hysteroscopy is a long tubular structure with a microphone with a camera at the tip connected to a screen. So you just go in, you observe the whole uterine cavity, and you can directly see it on the screen to tell whether the mass you are looking out for is exactly there. Now, the last one, which is not part of the diagnostic, but is part in most of the diagnosing or the workup for someone who have uterine fibroid, is called hysterosalpingogram. Now, what this one does is that if someone has uterine fibroid and you think that the person's uterine fibroid is causing her to not get pregnant, or it's obstructing any tube, you do that particular test and it will line all the uterine cavity and the tubes. And if one particular tube is not well lined, then it means that that particular tube is blocked. And this one gives you the kind of imaging for you to be able to tell if that had happened. Now, the gold standard for really checking whether someone has uterine fibroid is an MRI. So this whole structure you are seeing here is the uterine fibroid. Now, this is the uterus. The uterus starts from somewhere here. You can see it over here. This is the rectum, because I can see air, and this is the bladder, which is also which contains fluid. So this is the uterus, and it ends somewhere here. So all this structure we are seeing here, all that we are seeing there, all that we are seeing there, and all that we are seeing there, is the uterine fibroid they are trying to identify, and the MRI gives you a better imaging. Now, what can look like a uterine fibroid which is not uterine fibroid? So if someone comes to you and you are suspecting a uterine fibroid, the first thing you need to rule out is the person not pregnant, because those pregnancy symptoms can also look like a uterine fibroid. Then one cousin of a uterine fibroid is adenomyosis. It just looks like a uterine fibroid. They all have a fiber issue. The only thing is that while the uterine fibroid arises from one myoclonal cell, adenomyosis attacks the whole organ itself, the muscle itself. So it attacks the whole uterine muscle and causes that part to be damaged. So they almost look like myomas, but they might not be myomas. Then we have endometriosis. Endometriosis is when you have the endometrial line. What do I mean by the endometrial line? The part of the uterus that bleeds. Do you understand? Anytime you have your menses, that bleeds out. Sometimes these tissues can dislodge from the uterine cavity and be placed directly inside the uterus or on top of the uterus or around somewhere in the pelvis, and they are very, very painful. Their presentation just looks like that of a uterine fibroid, and you have to investigate it further to be able to tell that it's different. Ovarian tumors, ectopic pregnancies, and sometimes uterine cancers can all present as uterine fibroids. Now, let's look at how you manage it when someone comes to you with problems with uterine fibroids. The first thing is that, which is mostly the thing I see them do here, which is not healthy, is that they wait. They wait. Mostly if the size of the fibroid is less than 12. Less than 12 weeks means that it's not even up to the level of your navel. They might leave. They will not want to take any decision, or you are nearing menopause, which they know that at menopause your estrogen level will go down and it will increase in size again. They might, what we call expectant. We just wait to see what happens. Now, whilst we are waiting, you will be doing a follow-up every 6 months, and they will do a pelvic examination for you. They will take a baseline imaging, which is a CT scan, an ultrasound, and everything to tell us how we saw the mass, what was the mass, and how it is. Then after 6 months, they will repeat it again. If you are developing more masses or that particular mass is increasing in size, then something has to be done to avert what could be going wrong. Routine pelvic exams, as I said, and baseline imaging. Okay, please. Are you following?
We are following, yes.
I'm
yes,
a little
please.
bit on the speed, but if you have
really
any question, you
enjoying
can
it.
interrupt me and I will be back to talk about it. So from what we have learned so far, which I really want you to take into consideration, are these competing diagnoses: pregnancy, adenomyosis, endometriosis, ovarian tumors, ectopic pregnancy, and uterine cancer. That tells you that anytime you're having anything like abnormal uterine bleeding, anytime you're having anything like pelvic pain, and all that, kindly go to the hospital, get it checked, because it could be any of these things. Okay. Now, if the expector, which is watchful waiting, is not helping, and the person has some form of symptoms, then you want to treat medically. So the common practice is to relieve the pain, and you can use that. You can use NSAID. NSAID is ibuprofen, naproxen, diclofenac. These are all NSAIDs, and they're able to relieve you of the pain. But a sign of caution, or tranexamic acid. But a sign of caution is that these NSAID can have also a side effect on your intestine that can give you a peptic ulcer disease. So you might have to be very careful. If you have constant pain that is repetitive, then you might have to be careful. You have to go and see the doctors for the doctors to take a decision whether that tumor or that fibroid has to still be there. If not, he will take you to the theater and remove them. It also decreases, they give medication that decreases the menstrual blood loss. That is very, very important. You give a medication that stops. So Depo, Previa, and all those things sometimes are given. Progesterone only are also given to stop them still bleeding. And sometimes it helps them to prepare you during the preparatory stage, because those medicines can shrink the size of the tumor, so that if they have to go in and remove it, that wouldn't be much a challenge. Okay. Now, what are some of the drugs that are given? Progesterones or progestogens. So like the contraceptives can be given to help reduce the size and reduce the clinical symptoms. Or some of these drugs, which is anti-progestogens and GnR analogs. I should have gotten us a picture of one of these drugs. Please, how many of you know Zoladex? How many of you have come across that? If you come across, you can just send it a chat, or if you want to come out and talk about it. It's one of the commonly used drugs to treat uterine fibroid, mostly to reduce the size if you want to go in and remove the fibroid. Has anybody heard of it before? So those drugs, the GnR analogs, are the Zoladex, the triptorelin, and then the lipolide depots. These are very, very effective in decreasing the size of the myoma almost by 20 to 50%, depending on whoever is taking it. And it decreases your bleeding so that it helps you increase your HbA. It gives you blood loss during surgery and converts a hysterectomy into a myomectomy. Now, let me explain that. I will go into the types of surgical management, but there are two clear types of surgical management. Is either you are removing the whole uterus away, or you are taking all the myomas away. And it's sometimes very difficult to take all the myomas away, which means after some couple of years, the myomas start going back again. But hysterectomy is a permanent decision. You do it, and it takes the uterus out, and you are okay. But sometimes people want to preserve their fertility. And if that becomes the case, then you want to do the medication to reduce the size so that they can go in and successfully take the hysterectomy. Please, are you following?
Yep, we are.
And does it make sense?
Yes,
It
it
does.
does. Thank you.
You're always welcome. Now, with these drugs, they are very, very expensive. Back in Ghana, we were paying almost like more than 200, no, more than 150 or 170 pounds, which would be like more than $200 for a single shot of the Zoladex medication. And sometimes I need it either once every month or depending twice every month, and you have to take it for about 3 months. So it was quite on the high side. Even here in the UK, even after subsidy, I learned Zoladex is still there on the high side. So it's very, very cost effective. The cost is very high. And one of the side effects of the GNR analogs is that it can make you go into what we call medically induced menopause. Medically induced menopause. Because what the drug does is it virtually shut down your estrogen production. So it can let you go into that situation, and that side effects are things that people don't really like, because you start having the hot flashes, your menses become very irregular or don't come at all. And one of the side effects of the drug is that after some time, if you stop, it can reverse all the effort you've done. So all the myomas that shrunk can return it back to the same size again if it's left. Okay. There are newer therapies. Raloxifene, azoprilsin. I don't want to go into them because these are very high end NHS medication. I don't know how the UK will see them, but these are very, very expensive drugs, and they have to be recommended by a specialist before you can have your hand on it. So those are the new therapies. We also have the IUDs, which has a progesterone releasing component, and you put it there. It helps reduce the effect you put it there, and it helps you to reduce the size of the myomas. Okay, now let's look at surgical management. Please, are you following?
Yes.
So
I raised up my hand. I wanted to ask a question, but let's go.
I can go back to it. I'm not looking at Sophie, kindly help me be able to tell, because my screen is off the Zoom interface, so I may not be able to see if someone raised their hand. Please, you can ask your question before I continue.
Yes, I was going to ask that the last slide that you showed about management, I had a total hysterectomy as part of the management of the fibroids, which means everything, the whole thing was taken off.
Yeah.
And that was medically induced menopause. So I experienced the hot flashes and everything, which means my estrogen level is really, really down. But in effect, it actually helped me to stop the bleeding and everything. So I wish I knew this early about some years ago. But thank you very much. Thank you.
Okay. I will go into why they opted for those kind of the options. So let me start with the surgical management. So there are two major block of surgical management for the treatment of uterine fibroid. The first one is myomectomy, and the second one is hysterectomy. Now, myomectomy is that we are going in to remove the fibroids, like what you've seen here. We are taking in these small things and the bigger thing out of the uterus, and we will preserve the rest of the organ, which is the uterus.
Dr. Osei, can you please talk us a bit more about the image that you are showing? Is it a fibroid on its own, or is it a fibroid with other smaller ones on it?
So they are all fibroids of different size. So the first one is a very big fibroid. This one was measured, I think, 15 by 17 centimeters, if I remember. And these ones are like about 2 by 3, 5 by 5, or 4 by 5 centimeters. So these are all the uterine fibroids. Let me go up again and show you one of them. These ones. So it's the same like this. This is the biggest. So what happened is that always when someone have uterine fibroid, there's one big one that is in there, and these small ones that are out there. Now, if you take this one out and you leave this one in 2 years' time, you come and these ones are like that. So when you have the opportunity to remove, you remove almost all of them that you can feel or find out of it, and you'll be fine. So this is the uterine fibroid. That's how they look like when you've taken them out. Good. So that is the uterine fibroid over there. Now, there are many ways of doing the myomectomy. I wouldn't bore you with the difference and which one has to be done first, but I will just explain them. So we have what we call the abdominal myomectomy, or laparotomy, what we call laparotomy. So they make a big incision on your abdomen, either fenestal or straight line on your abdomen. They go in, bring the uterus out, and they cut it down. So let me show you this one. This is this picture. What we see here, this is a laparotomy. They've done an incision in the abdomen, brought the uterus out, and now they are going to remove this uterine fibroid. It's called laparotomy, myomectomy. So that's what it is called. Good. Then you can remove so that is the first one. Still within the abdomen, you can do what we call laparoscopic. Now with the laparoscopic, what they are doing is that they are trying to they cut small incisions on your abdomen, then they use a probe, a device, to go in and remove the fibroids out so that they don't have to do a big scar on your abdomen. Now, that helps, that you can only do that if the sizes of the fibroid are small. You can't do it for a big size like this. You can't do laparoscopy for a big size. Some people have attempted, they take it, chunk it one by one before they bring it up, but the risk of bleeding extensively is always high when you do that. So a big fibroid like this, you have to go for laparotomy, not laparoscopy. But if they were small like the ones on top, yeah, you can attempt a laparoscopic one. Then the third one is what we call hysteroscopy. They go through the vaginum, through the cervix, and they go in, and mostly when you want to remove what we call this intramucosal, the submucosal fibroid, you can go through the vaginum to do it, and it's quite very effective, and people have a lot of success about it. Now, why do you want to do a myomectomy? Why do you want to choose a myomectomy over hysterectomy? In case that the person you are going to do the procedure wants child, then you can't take the uterus away. You need to keep the uterus and just take the fibroids out. If the person is getting recurrent pregnancy loss and you rule out any other cause of pregnancy loss, except that the person have uterine fibroid, then you want to go in and do a myomectomy and remove the fibroid so that the person can give birth. And in younger patients, you don't want to do a hysterectomy because there will be always a desire for the person to change his mind to want kids. So you don't take the uterus out in that situation. Then the desire to preserve the uterus and fertility. If the patient tells that she wants their uterus and they won't have more children, you can't take the uterus out. So I've told you about the pressure symptoms and if the person has pressure symptoms such as pain, abnormal uterine bleeding, or whatever is happening to the person is affecting their quality of life, then there is a duty and there is a duty for you to go and remove the masses out of it. Okay. Now let us look at hysterectomy. And that's what Mami was talking about. Hysterectomy is when you are taking the uterus itself out. The uterus itself out. Now, with myomectomy, they have what we call the subtotal hysterectomy. What that happens is that you are only taking a part of the uterus. That person gets the ovaries, that person gets the cervix, majority part of the cervix is still retained for that person. And it's called subtotal hysterectomy. Now, on the other hand, is the total abdominal hysterectomy. Then what they do is that they are taking everything that is related to the uterus away. That including the ovaries, the uterus, end the service because of the risk of, if there was a tumor, the tumor coming back to harm the person. So you do total abdominal hysterectomy. And sometimes they spare the ovaries because the ovaries might still be producing some amount of the estrogen. But if they don't spare the ovaries and they take everything out, it means that probably the ovaries themselves may not be healthy or may not be showing signs of healthiness, and they want to be sure there's nothing wrong with you, so they take it out. And when sometimes you've reached your menopause, they don't want to even waste time at all if the uterus has started developing very, very bad masses. Okay. And also, if the person has pressure symptoms that is affecting their quality of life, then you may want to also take a decision on that. Yeah, there are innovations in now the surgical field where they are using other sources to treat the myomas. Now, one of the common ones which has a lot of breakthrough is this one. Is when you use you embolize the artery. What it means that you stop blood supply from that particular artery to the potential side where the masses will be. Do you understand? You are stopping the blood supply to get to the masses. So they put in a catheter through the femoral artery in the patient's leg, go there until they reach the ovarian arteries. And when they do, they block the ovarian arteries. And when they block it, blood supply to that particular mass is cut off, and that can kill the mass gradually, or it could cause the mass to be expelled from the body. So it's a procedure. Then the other second procedure is the use of something that looks like a laser to target the cell itself, or target the end part of the blood vessels to kill the blood vessels, so that the blood supply to that particular mass is impeded. And when that is impeded, then everybody will be fine. So these are the new interventions, mostly when it comes to surgical, and they are still being some of them are under review, and we'll see how it goes. So upon that, this brings us to the end of uterine fibroids, but I'll be so happy to answer a lot of questions for you. Thank you very much.
Thank you.
Thank you, Dr. Osei. Yeah. If you could please
you.
stop sharing now, Dr. Osei, so that we can ask people to put their hand up, and if possible, to put on your camera so that we can see some faces to make it more lively. Yes.
Just give me a minute to get water.
Okay. Whilst Dr. Osei is getting his glass of water, I can't see from my screen. Are there any hands up? Yes. So yes, I can see. Yeah. Okay. So Sister Millie, sorry, Glenda, go on.
Oh, I was just going to say that there was one question that was outstanding in the chat. So I just wanted to make sure that it was addressed.
Okay. Linda, can I leave you to facilitate or moderate the questions and answers with Dr. Osei then?
Oh, sure.
Yeah. Okay. All right then. So go ahead.
Okay.
Thank you.
But it sounds like Millie, the person that had their hands raised, was going to ask the question. So maybe it will be addressed.
Yes, I was going to ask a question about embolization and total hysterectomy.
Okay.
So I know embolization is sort of starving the fibroid of blood so that eventually dies away. Can it be a case where it doesn't actually succeed, or it comes back after some time and you might need a total hysterectomy in some cases? Thank you.
Yeah, so my answer is yes, because the uterus has several supplies. The uterus has several supplies. the targeted are the main uterine arteries, which they try to target. Now, mostly, it might not necessarily disappear, but they will significantly shrink in size. And if they shrink in size, some of the symptoms might resolve, or it will help for the doctors to go in and remove it without a lot of complications. So that's mostly the efforts that the embolization does. But yeah, it's one of the procedures that has a lot of success, but it's not always 100%.
Thank you.
You're welcome, please.
Yeah, thank you. I see, Millie, you had your hand up, and you can come off of mute, but I did want to acknowledge that you had a question earlier on in the chat.
Yeah, thank you. Doctor, I just wanted to ask, what can we, so the first question I put in the chat was about, I think it was about the second or third slide that you discussed about medications that can stop, I think is
this one. Oh, I'm not sharing, sorry. Is it the medication that can reduce the size of the...
the family planning medication that can stop the growth of estrogen so that the fibroids are not fed. So I think you discussed something about some medications that could help, contraceptives actually, that could help decrease the estrogen feeding the fibroids. So that could decrease the fibroids. That's my first question. Yeah. My second question is, after you've had an open myomectomy, what could one do to try and minimize or prevent regrowth?
Okay. So the first question you asked about drugs that can reduce the growth of myomas. There are a lot of them. Actually, it is believed that progesterone-only contraceptive is just, some of them are orals, and now we have an IUD version of it. They actually help. I don't know whether we've heard of Melena coil. Melena coil has been very successful in helping reduce the size of myomas. But progesterone-only pill, POPs, are also very effective in reducing the size of the myomas. But those are very temporal. They are not the effective ones. When it comes to the effective ones, that's where you bring in the big guns like the Zoladex, the triptorelin, and the Liprolise. Those ones too have a lot of side effects. As I said, they can let you have a medically induced menopause, and but it's very effective. It can reduce the size of the myomas by 20 to 50%, and that can help you manage your symptoms, or that can help with controlling the size of the uterine fibroid. When it comes to the second part of the question, which is what can you do in person to reduce the myomas from coming? You might not be able to reduce it completely from coming, but what you can do is you can slow the growth of the myomas. So it is believed that when you eat green stuffs, green food, it helps reduces the growth of myomas. If you reduce your size, if you are obese and you're able to cut down your size, it also helps a lot. Those are and if you exercise, those are the three main things that are very important when it comes into you trying to control them. So you eat a lot of green foods, you do exercise, you can get a progesterone only pill that really also help. But apart from that, there's not much to do. But if you're also in your reproductive health, or you are still within reproduction and very fertile, you can still go for some kids, and that helps because it is believed that when you are having kids, the estrogen level diminishes, and it helps reduce the size of the It helps prevent growth of the myomas. Okay, is your question answered, please?
Yes, please. Thank you. But just as a follow-up,
Okay.
so in reality, someone who's gone through either a laparoscopic or an open myomectomy, you can't stop the fibroids from you can't stop them. So essentially, you might be having multiple surgeries until maybe you have a what's it called, a hysterectomy. Maybe not a total hysterectomy, but some sort of hysterectomy.
Not necessarily. So what the open myomectomy does is that it can remove every visible myomas. The ones they can see, they will remove them. But there are the ones you cannot see. They are very microscopic that the eyes might not be able to see. But all the bigger ones can be gone. And it's the smaller ones that might start developing again. So what you can do is you can slow the process. And also after some period of time, the moment you get into menopause, those ones start going down again. So yeah, I let me give you an example. My eldest sister had done 3 surgeries because of uterine fibroids. She did one in Ghana. When she came here, she did another one. And when she was having childbirth, she did a third one. So there are people who have the high risk and propensity of having recurrent myomas and having surgeries. But there are few people, after they do it once, it never turns up again. That's the case of my wife. She did it once, the myomas never turned up again. Or we've not picked any myomas on scan after that, and that is like 7 years now. So I can't tell you exactly, but some people it won't come again after the open myomectomy or laparoscopy. Some it might come. And that's where genetics plays a lot in this kind of scenarios.
Okay, thank you so much for your help. Thanks for your time.
Thank you. There's another question in the chat that asks, does fibroids developed during pregnancy automatically die away?
Not necessarily. Not necessarily. So during pregnancy, 2 things happen. So there are 2 things that happen concurrently during pregnancy. The first one is there are growth hormones or growth factors that will support the growth of myomectomy, that of the fibroids. That's the first one. The second one is because estrogen level is so down, apart from the growth hormones, the supply of estrogen to increase the size might be taken away. And the third one is that the baby itself will be competing for blood with the myomas. So yes, the myomas can die when you are having pregnancy. But again, because of the growth factors, some of them can increase significantly in size. So those are the pull and pulls of it. If you have it before you got pregnant, then it can only shrink. It won't disappear completely. But it is believed that if you have more than 2, 3, or 4 pregnancies, and you started getting pregnant early, then you may have a lifelong prevention for the from the myomas or from the fibroids than someone who developed the fibroids and now getting pregnant. They have a higher risk of the fibroids growing up to become a little bit bigger.
Okay, and I think the person put that is after delivery. If you can come off of mute and kind of share your follow-up question.
And the sword comes and takes any one of them. That person is.
Okay. All right. Well, there's another question in here. I understand eating lots of carbohydrates doesn't help. Is that correct?
Yeah, that is partly true. So anything that will give so anything that increases metabolism, which carbohydrate is one of them, can cause a turnover in the growth of myomas. So I always say just balance it. Just get a lot of greens, little amount of carbohydrate. Carbohydrate doesn't help in anything. It just stores too much energy for your body to utilize. And if it's storing too much energy, the tumors will take advantage of those stored energies and utilize them to grow. They just want to grow. They want to get bigger. So if there is food, they will get bigger. So just cut down the carbohydrate, increase the greens, and you still have the health benefits of all of them.
Okay, thank you. There's no more questions in the chat. Sophia, would you like to?
Yes. Dr. Osei, I want to check the increased advertisement for herbal medication and increase in fibroids. What is your comment on that?
Okay, so it's really a challenge in Ghana because a lot of things, the way we've allowed the free, how do I call it? The free advertisement of these things is a worry. Herbal medicines are good. There are known herbal medicines that can help reduce the growth of fibroids. There isn't enough evidence or research to support them, but I know there is. I know there is. Now, the issue is that you can't use herbal medicine to reduce this, this is what they say, to melt the fibroids. If you understand the anatomy and the pathophysiology of it or pathology of it, it's not possible. How their claim is, it's not possible. The best bit is that it can help reduce the size. But I don't think the herbal medicine alone can cause the fibroids to grow up. That I don't think. So I can't give you a very good answer on that particular matter because I don't have a lot of information on it. But what I can say is that herbs have the propensity. Some of them might have the capacity to reduce the size. I don't think it can cause the size to increase, but also I don't believe that the herbs can cure fibroids. The only thing that can take away fibroid is surgical interventions. And that's what we've done. We've talked about either myomectomy, hysterectomy, or sometimes some of the surgical embolization. Sophia, you're muted.
Yes, sorry. So my next question is, in your time of practice, how long does it take? I know this would differ from individual to individual, but on the average, how long does it take for the growth to become so much that it becomes concerning? How long does it take? So let's say someone has gone for a scan and there are no symptoms, and then there is a fibroid of, let's say, about 2 centimeters, 6 centimeters. How long does it take for it to get to that stage where it becomes very concerning?
Yeah. So I'll use an example, a very typical example. I have a friend here in the UK. We came to the UK around the same time. Now, back in Ghana, I was the one who diagnosed her of uterine fibroids. It was just one uterine fibroid on top of the fundus of the uterus. Now, she started having irregular menses, sometimes profuse menses, blah, 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 blah. She was a little bit in her almost getting to mid-30s or somewhere mid-30s. Then she started having severe menstrual pains. Just, let's say, I came to the UK 2023. So let's say a year or two before I came, because that was when I had returned for my master's. I went back on 2022. So let's say from 2022. So the size of the fibroid then was about 5x6, or let's say 5x7. It wasn't big at all. It wasn't concerned. But the issue was the severe menstrual pains and the menorrhagia and everything. So I remember myself and my consultant decided that we wanted to take it off for her because it started affecting her quality of life. Her concern was that she's not giving birth before and everything and everything. And so she wasn't quite interested about the surgery. So fast forward, last year, which is 2025, that is 3 years after she opted not to do, the size of the uterus jumped from the 6x5 to about 15 by like 18 or 20. That is a significant jump. And I had to help her here to get the myomectomy done here. It was so severe she could not sleep. She could take morphine, codeine, paracetamol, all the classes of medication together, and she will still not be relieved of the pain. So I had to write some letters, referrals, and she got the surgery done here in the UK. So in a space of 3 years, let me say, with what I know from practice, a uterine fibroid can be significant and start causing significant harm.
Okay, and of course, you've talked us through some of the factors that can help with the growth. Yes. Okay. All right. So, what is the biggest of fibroids? I know I've asked you this question before we started, but now that we have everyone on, what is the biggest that a woman can carry?
Yeah, it can become very big. You know, it can swallow the whole uterus. You can have a size of like a ball, of a soccer ball. It can go that kind of big. I have seen that of almost 2/3 of a soccer ball. That was really huge. So yes, it can really grow. If it has all the blood supplies, it has all the nutrients it needs, it will keep growing. But most of the time, it doesn't get there. It doesn't get to that very big, like a soccer ball, because then you will have all the symptoms. They might take medical, like they will seek for medical attention before it gets there. The biggest I think I have taken out was, or together with our surgical team took out, was almost like 18 by, let's say 18 by 20. And 18 by 20 is this size. Like, it was really significant, this size. So yeah, it can really go big.
Okay. There's a question from Millie. It says, can stress affect the growth?
Yes, I totally believe anything that triggers. So I'm using the word, there is anything that causes your body to increase its turnovers and increase its metabolism can cause it to grow because it has a link to growth factors. So yes, I think stress can get it to grow, but that has not been proven, or that has not been justified. But I think it can.
Okay. There is a question from Auntie Jenny. Can fibroids get infected?
Yes, it can. So one of the common complications of fibroid is getting infected. And let me give you the scenario. So this is what happens. So let's say you have a fibroid, there is a competing for blood supply, and the blood supply to the fibroid is reduced or stopped. The fibroid undergoes something we call necrosis. That's the red degeneration. It starts degenerating. And when it starts degenerating, it forms what we call necrosis. And the middle of it is like a slough. It's like, how do I call it? When you have a sore, like a wound, and it starts developing a slough. That part can be infected by any organism. So there are fibroids that are really infected, and they are really bad. And some of those are some of the complications that you have to take the person to theater and take it out. Because the shell of the fibroid is so tough you won't be able to get antibiotic to go in and clean the infection. So one of the things you have to do is to go and take the infected fibroid completely out.
Wow. Another question from Auntie Jenny. What are the symptoms to look out for?
Okay, so let me run through the symptoms again. So I gave three classical different symptoms. The first one is the asymptomatic symptoms. When you have a lot of abnormal uterine bleeding during your normal menses, you pour so much. Some people say they use about 2 or 3 sanitary pads before the end of the day. That is abnormal uterine.
Sorry, doctors. I think her question is a follow-up on the infection. So what are the symptoms to look out for an infected fibroid? Yes.
Severe pain, severe unrelenting pain. So you know that you have a history of uterine fibroid. You have a history of uterine fibroid. Then you start developing severe pain at that particular side of the fibroid, which you will know because you know that's where the fibroid is. You have severe pain, and the pain sometimes is just unrelenting, and you start developing fevers, chills, and those things, the signs of the infection. Then the doctor will think that probably the uterine fibroid is undergoing red degeneration. So we'll go and take a scan. The scan can tell us whether it's undergoing degeneration. If it's undergoing degeneration, then we can suspect that the fibroid, which is undergoing degeneration, has gotten infected, and we may have to go in and take it out.
Okay. All right. Yeah. Linda, should I hand over to you?
I think you've gotten all the questions in the chat, so I think we're good. Oh, okay. I think Melly has her hand up.
Hi, Doc. Sorry, one more question. Is there a correlation between period pains and fibroids? And if one has had an open myomectomy, would that automatically make the period pain disappear? And I mean extreme period pains.
Yeah, definitely. So period pains is really associated with fibroids. So if that is so, and the fibroids are taken out, the period pain should stop. So let me give an example. One of the reasons why you do surgery is that you're having these kind of symptoms. So when someone have let's say someone 27 years, 8 years, 29 years, have severe dysmenorrhea, a doctor may opt not to do myomectomy because they want her to try and get pregnant first, because some of the myomectomy can actually also affect pregnancy. But one reason why the doctor would decide to go ahead with the myomectomy, irrespective of the risk of infection, is because of the period pain. Because some of the period pain are so unbearable. I've seen some that it just doesn't make sense. There is no amount of medication that helps. In that case, you go do the myomectomy. And after the myomectomy, when the wounds are healed, all the pain goes. If not, it goes to the barest minimum, where the person can tell you that if their pain was 10 out of 10, it comes as low as maybe 2, 3, or 4, which they can now bear it. So yes, period pains are linked to fibroids. And if you do open myomectomy and you take them out, they become okay.
Thank you.
Thank you very much. There was a follow-up question on the infection. So Auntie Jenny wants to know, will this lead to emergency surgery?
Yes, it might lead to emergency surgery. So let me give you the classical one. So when someone have infected fibroids and it's undergoing what we call red degeneration, the doctors will want to be careful because it could also be a torsion. Do you understand? And it's quite difficult to tell a torsion from an infected fibroid. So yes, when that happens, it's an emergency because they will present with every serious symptom that has to be, and the doctors have to go in and take it out. So yeah, but some might try to treat it, and if they are successful, then they can postpone the surgery, because surgeries are always surgery. Any surgery is a surgery, and surgeries have its own complication. But if they try and there is no progress with it, they will go in and solve the problem.
Okay. Thank you, Dr. Osei.
You're welcome.
I can't see any more questions, and I can't see any hand up. So I think that should bring us to the end of our first session. And thank you very much. It's been very successful. So we are going to upload this. We'll edit it and upload it for people to go back to with the information that you've given us here. So Dr. Osei, thank you very much. And before you go, when is our next one, please?
So we agreed we will do it quarterly, right?
Yes.
Okay, so we will take on the next topic in the quarterly. We've discussed some couple of topics, so probably we can
I just want to whet people's appetite so that they will look forward to the next one.
Okay, so we discussed that we might be doing something like a polycystic ovarian syndrome. That's one of the topics on our minds.
Yeah.
We also talked about premenopausal syndromes, which is very difficult to diagnose, and some people start having the things and they don't know what is happening. And what was the third one? The fourth one?
Cervical cancer. Cervical cancer,
yeah. Cervical cancer is one of the things that is becoming a problem. It's really a big problem, and it's one of the conditions like myomas, which can easily be treated. It's one of the cancers that you can really cure. So we want to talk about it so that we know about it and we quickly gather ourselves with knowledge. And when we start experiencing anything like that, we can really go about it. Yeah, and someone has suggested endometriosis. Yes, I'll be so happy to talk about endometriosis. Is the cousin of uterine fibroids, and they cause a lot of troubles for people who have them. I'll be very happy to talk about endometriosis.
Okay. All right, then I will suggest as a follow-up to uterine fibroids, we can do endometriosis for our next one.
That would be great. That would be great.
All right, then. So thank you all for coming today. I know it was a very short notice for Dr. Osei and for everyone who attended. So thank you all very much. I can see Dr. Brobe on. Dr. Brobe, thank you. And every one of you, Auntie Tilly, Auntie Jenny, everyone, thank you all so much. And so, yes, we will call it off now, and we will announce the next show very soon. Thank you all for attending. God bless.
Thank you.
Bye.
Thank you very much. Thank you. Bye.
Bye.